So we're going to talk about the flu vaccine. This is obviously another really important issue that's pertinent to everybody. So what is flu? Well, hopefully you're all aware it's an acute viral illness of the respiratory tract. This is just a comparison on our website between flu and a cold. It is very much worse than a cold, and it is quite a severe infection for some people. Oh, there we go. I did press it. So what is an influenza virus? I have to go back now, don't I? There we go. No? Yes, got it. So there's two main types of influenza viruses, flu A's and flu B's. So it's the A's that usually cause the outbreaks, and they're usually the cause of epidemics, and they usually have an animal reservoir as well. We saw that with swine flu and also with bird flus in China. And then B's usually tend to cause less severe disease and smaller outbreaks, and you would usually see more burden in children, and it would usually be near the end of the season, although we didn't see that in 17-18, which we'll come to, and mainly it is seen in humans only. This is what a flu virus looks like. And the main thing to notice is the little spikes on the outside, the H's and the N's, hemagglutinins and neuramidases. And that's essentially when we talk about H1N1, H3N2, that's what we're talking about, the little spikes on the outside of the flu virus. And what happens with the flu virus is changes in these H and N's happen constantly, and that's why we need to change the vaccine each year. So there are small changes that happen every year, which is called antigenic drift. They're small natural mutations that occur gradually over time. And there's other big changes that happen sometimes, antigenic shifts, which when we get a new subtype, people aren't immune, they've not had this before, they've not been vaccinated against it before, and that's where you get maybe a widespread epidemic or pandemic. And because of this, the WHO has to monitor the epidemiology of flu across the world. So in the southern hemisphere now, they're looking at their flu season, and they'll be looking at our flu season in the winter. And every year they make recommendations about which strains of A's and B's they think need to be in the vaccine for this coming season, and that's when the manufacturers then develop the vaccines. So what happened this season? This season we had a mainly H1N1 season. And the current vaccine, it was quite a good match for it, which was great, but we still did have a lot of people going in Ireland to critical care, 131 people, over 3,000 people hospitalised, and 71 deaths notified to HPSC. This is from their weekly influenza report, so that's not the final data. And we had 95 outbreaks of ARI, acute respiratory infection, or influenza outbreaks reported in the season. So still quite a lot of people had hospitalised, and people died from flu this season. This is just again from the HPSC report. It shows the last two seasons. So the blue is the influenza A and the yellow is the influenza B. And you'll see last year we had quite a lot of B disease, which was unfortunately I think a mismatch for the vaccine. And it was quite a severe season. And this season it's been nearly entirely influenza A and actually much less severe season. So we never quite know what season we're going to get until we're there. So how's it spread? It's spread from person to person by aerosol droplets and also on contaminated surfaces. It's extremely infectious, and obviously close environments like homes for the elderly, it's particularly severe, and spread can be easy. It's very contagious. You're actually contagious before you get the symptoms, as well as after the symptoms, and you can shed very prolonged in young children and in the immunocompromised. And in the UK, as you know, and I spoke to you about last year, they've been vaccinating all children from 2 up to 11, and because essentially children are seen as the super spreaders, and that has had quite an effect in flu across the whole community. And asymptomatic people can still shed the virus and infect other people, and that's very important for healthcare workers. You might feel okay, and you might carry on working, but you might infect your people that you're caring for. So although some people are asymptomatic, there are outbreaks occur, there can be significant morbidity and mortality. You get a sudden onset fever, runny nose, cough, muscle aches and headaches. You can get a pneumonia, either primary viral pneumonia or a secondary bacterial pneumonia, and flu can actually go on and cause bronchitis or meningoencephalitis. Your illness is more severe in the elderly, also people with various chronic illnesses, children under the age of 4, and if you remember from Suzanne's graph, there were actually quite a lot of children under the age of 4 who were hospitalised and who were in intensive care. It's also important to remember people with neurological conditions and pregnant women, although the majority of our deaths are usually in the elderly. So who needs to be vaccinated? You've probably seen this list before, and it's an extremely long list of people, but I'm going to wake you up a little bit. I want a straw poll. Who thinks of the chronic diseases under the age of 65 if we think about heart conditions, lung conditions, liver conditions, diabetes, and neurological conditions. Who would vote that heart disease is the worst? You should go for the people with heart disease first. Okay. Lung disease? Diabetes? Neurological conditions? Liver disease? Okay, they're all down there. And this was some work that was done in England quite a long time ago now. What they noticed for the under 65 uptake, diabetics very good at coming in, always having their blood sugars checked, very high uptake in diabetics, quite high uptake in people with lung conditions, maybe COPD, maybe they're always coming in and out of the practice. Very poor uptake in people with liver diseases and chronic neurological conditions and immunosuppression. And so actually PHE did some work in the September 2010-11 season, and they looked at the relative risk of death from flu for people with any risk groups compared to no risk group, and then they broke down the different risk groups. And what you'll see there, any risk groups compared to none, you've got an 11 times greater risk of dying. But if you look here, the diabetics have only got a 5 times greater risk than no risk condition. You've got, or I can try and point, can't I? You've got your respiratory disease, it's only 7 times. Your diabetics are 6, your heart diseases are 10. But here, your liver diseases, nearly 50 times greater risk of dying. You've got your chronic neurological people, 40 times greater. Your immunosuppressed people, 47 times greater risk of dying. So these people that we don't think about, none of you are really voting for those people. Those are the people that we need to target. It's not those people that are easy to reach, the diabetics, the respiratory people that come in all the time. So really important, those people are also really, really important to get vaccinated each year. And I know this was done in England, but I can't imagine the picture is too much different over here. So another really important group that came in more recently is the pregnant women. I'll be our lifesaver. She's being a lifesaver for herself and her unborn child. Why are we recommending pregnant women to be vaccinated? Well, the WHO Strategic Advisory Group of Experts on Immunisation looked at this in 2012, and they actually recommended pregnant women as the most important group for flu vaccine. They saw that based on very significant evidence of substantial risk to the woman herself and also her baby. There's lots of evidence the vaccine's safe and effective in pregnant women, and it protects their babies when they're very young, and disease burden can be very high. So we recommend flu vaccine in all stages of pregnancy. Pregnancy is a risk group, and pregnant women should be vaccinated every year. It takes place obviously during the flu season, but women can become pregnant throughout the flu season, so identify them early if they're already pregnant in September, October, and vaccinate them then. But if they become pregnant in December, January, then they need to be vaccinated then. So do remember to offer those later people as well. And do remember they might need revaccinating. If they're pregnant at the beginning of their pregnancy and the end of one flu season, they're still pregnant when the next vaccine comes in, they need to be vaccinated again because the flu vaccine changes every year. So we must do that. And again, they need vaccination in each pregnancy for the same reason, that the vaccine changes every year. And like I said in the pertussis talk, don't wait to give flu and pertussis at the same time because it seems easier. Make sure you vaccinate that woman at the appropriate time. And one thing I do think is important in practice is just an anecdotal thing in terms of your receptionists. Are they making it easy for people to come in? Do your receptionists understand what our current guidelines are? This was a few years ago, but I was in England at the time and I was pregnant with my second child, and I tried to get a flu vaccine appointment with my GP, and the receptionist said, "Oh, what trimester are you in?" And I said, "Doesn't matter." She said, "Yes, it does." I'm like, no, it doesn't. I can tell you it definitely doesn't. So she was going to block me from getting that appointment because she had a preconceived idea, and possibly at the beginning it was only licensed for second and third trimesters. Now it's licensed for everything. So those are the people maybe we don't think about. Are they the people in the practice that's not letting these people come through and get their vaccines if they need it? So pregnant women, very, very important. So the flu vaccine itself, Simon Harris has given you a little spoiler about what we're using this year, but the WHO has made its recommendations. The recommendations for the quadrivalent vaccine are as such. We always have an H1N1 and an H3N2, and then the quadrivalent has 2 different B types that the WHO feel are going to be most likely to be circulating. Unfortunately, they were a little bit late in their H3N2 component recommendation. We're hoping that's not going to have a knock-on effect for the development of the flu vaccine. But if there's any news on that, we'll let you know, obviously, as soon as we can. But that's what's going to be in the vaccine this year. So this is what we're using for this coming season, 19-20. It's called the Sanofi Pasteur Quadrivalent Influenza Vaccine Split Viron. Now, that's not a very snappy title, but unfortunately, it doesn't have a snappier title. That's what it's licensed as. That's what it looks like. It comes in boxes of 10 and in singles. If you want to give it a little snappy title, you can call it QIVE. So that's a quadrivalent influenza vaccine, egg-based. Obviously, like all vaccines, and Clearan will talk about storing it in 2 to 8 degrees. It's licensed for everyone 6 months and over. There's another quadrivalent out on the market that isn't. So we've got the 6 months and over. Everyone can have this one. IM dose, 0.5 mils. What's in it? It's got a low of albumin content, so less than 0.1 microgram per mil, so it's got a low albumin content. It may contain traces of neomycin and formaldehyde, but it doesn't have gelatin, doesn't have thiamersyl, and it doesn't have latex. So this is sometimes a question, 1 dose or 2, who needs what? This is actually just taken from the NIAC guidance, and you can find that on the website very easily. But essentially, children from 6 months to 9 years need 2 doses 4 weeks apart if they're having their flu vaccine for the first time. And then there are some other recommendations there for other people who've had transplants or who are on chemotherapy who might need 2 doses. Everyone else just needs 1 dose. Who's contraindicated to have the flu vaccine? I'm a bit of a broken record, but anyone who's had a confirmed anaphylaxis to a previous dose of the flu vaccine or anything that's in the vaccine. And obviously, you will need to be competent and trained to manage anaphylaxis, even though it happens extremely rarely. So what about egg allergy? I've said that we've got a low egg content vaccine this year, but this is again taken from the guidance. So people with confirmed egg anaphylaxis and egg allergy can have the low egg content vaccine. If you've got a non-anaphylactic egg allergy and you don't have severe asthma, you can have that in primary care. If you've got egg anaphylaxis or egg allergy with severe asthma, then it's recommended to have it in a hospital with a specialist. So what are the adverse reactions for this flu vaccine? You might have local reactions, as you'd expect, local injection site pain, redness, swelling, etc., very common. Very common for this vaccine are also listed as headaches, muscle pains, and feeling generally unwell. Common is fever and shivering, and very rare are these allergic reactions. But the most important point to remember is it's inactivated, not live, and it definitely isn't going to give you flu. So how do we do in Ireland? This is actually from up to 17-18 in terms of our people over 65. We're not really meeting the target in terms of the over 65s in terms of uptake. So we're around sort of 55-60%. So we do need to do better. We could do better. And moving on to another point, Simon Harris was talking about this too. In terms of ourselves as healthcare workers, we need to step up to the plate and be confident in vaccinating ourselves, as well as encouraging our patients to be vaccinated. So we need to be those lifesavers and get the flu vaccine ourselves. So we have recommendations for flu vaccine and healthcare workers, and these are the recommendations. Everyone working in healthcare should be immunized, so we all should be immunized. We do it because we protect ourselves, and we go home and we protect our families. We don't bring it back from the wards or the practice to infect our families. We reduce the risk of transmission to our patients. We make sure we protect people who don't respond themselves very well to the vaccine, and we also avoid disruption for care services because we're not off sick. So these are the staff groups. Essentially everybody, medical, nursing, allied health professionals, including students in all those disciplines, dentists, porters, carers in care homes, and all GP practice staff, and anyone in agency in those categories. So how do you get vaccinated? Well, line manager through Occy Health, through your GP or your pharmacist. And we've already talked about HSE Land. There's an e-learning program, again, for flu vaccine, and you can do that and become sort of more up to date in terms of the flu vaccine program as well. So I was just going to make a brief mention of other newer flu vaccines. We do get some questions each year about these flu vaccines. Some people do still seem to look at maybe UK or other sources of information for the flu vaccine. So just so you're aware that there are other vaccines. So we've got the LAIV, the live attenuated intranasal vaccine, the Fluens. That's the one we've been using in the UK for a few years for the children. They're new onto the market and newly used in the UK for the season that we've just had. It's something called FluAd. That's the adjuvanted flu vaccine for the over 65s. Then there's something that's coming onto the market for the next season in the UK, which is called a high-dose trivalent vaccine. That's also only for over 65-year-olds. And then there's something called the cell-based quadrivalent vaccine. I did say you could call the vaccine we've got this year QIVE, and that's to differentiate it from QIVC, the cell-based. So what they've noticed with the H3N2 virus is that it does seem to change. It doesn't seem to have been so effective in the vaccines in the recent years. And they think possibly it's to do with the fact that it's grown in eggs. And they choose the right virus to go in the egg, and it maybe changes a tiny bit as it's growing to become the vaccine. So this is a new kind of development of vaccine where they grow the vaccine in cells instead, and it's hoped that this is going to be a much better in terms of picking the exact type of virus for the vaccine. However, what I've said here is that the JCVI have put a non-preferential, so that's the UK Vaccine Committee, a non-preferential recommendation for these new vaccines in the UK for the coming season. And that's basically because they're very new and there isn't really much head-to-head data to say this one's better than that one. We should definitely use this one. So we're kind of watching this space in Ireland to see which one actually looks like it's going to be the best vaccine. So none of these vaccines, even though I've mentioned them, and even if you read anything about them, we're not going to have them as part of our national flu programme for this year in Ireland. And we're not aware if any of the companies are going to be marketing them on the private market. So I don't know if they're going to be coming around and selling their wares and telling you that these are good vaccines. That would be entirely up to them, but they're not going to be used in our programme for this year. But just so you're aware that they exist. And that's all I was going to say. Thank you.